Guys, this is Mobeen. We are talking about the respiratory system pathology, and the lecture today is tuberculosis. So we'll talk about the pathogenesis, morphology, clinical progress of the tuberculosis. So let's start with the epidemiology. Tuberculosis was a more prevalent disease in United States in 50s. And since 50s there had been a steady decline till we reached 80s when AIDS surfaced. And due to that, the immunocompromised patients or patients with AIDS started contracting tuberculosis. So that downward fall became stable or decline stopped till that the medical community figured out how to start managing the patients who are immunocompromised plus they have tuberculosis, or how to prevent tuberculosis. So now the decline has started again. Current state is that in United States there are about 25,000 incidents of the tuberculosis yearly. Out of those, 40% are actually the immigrants who are coming in. So it's really promising. However, worldwide, WHO's stats are that out of all the deaths, 6% of the deaths are because of tuberculosis. So it is quite prevalent outside in the, especially in the developing countries, especially in the areas that are impoverished, that are poor, where hygiene is not great, where moisture is more, where nourishment is not sufficient. These are the unfortunate people who are more affected by tuberculosis. This is why also that tuberculosis, or this pathogen, is said to be the single most common pathogen that can cause death by itself. So it doesn't have to be a super infection on something, it doesn't have to be combined with other pathogens, just TB pathogen itself is responsible for 6% of the total deaths worldwide per year. So now let's talk about the etiology. Now for the etiology, what causes is, of course, the pathogen is Mycobacterium tuberculosis, and the reservoir for humans is humans. The human one is Mycobacterium tuberculosis hominis. It is also in the cows, for example, or animals. So Mycobacterium tuberculosis bovis is also a species that is actually that can affect humans. And then there are Mycobacterium avium as well, which is usually less prevalent and less vulnerable, less virulent. However, for the patients who are immunocompromised, 10 to 30% of those patients get infected by the Mycobacterium avium. Now, what is the mode of transmission for this pathogen? The mode of transmission normally is the aerosol from an infected patient. So patient is coughing, or patient is talking, or you are around that patient, and as the aerosol is formed, the droplets from the patient's breath, when you inhale them, these are the droplets that carry the pathogen from human to human through the aerosol. In the past, at least for the United States, in the past there was also a mechanism of transmission that was for the Mycobacterium bovis, which was drinking the unpasteurized raw milk from the cows. So infected cows had the Mycobacterium in their milk, and when the humans will drink that, that would cause infection, especially of the gastrointestinal tract. That infection in United States, at least because of the pasteurized milk and because of the hygiene for the animals, that has declined. However, still in the patients we can find gastrointestinal tuberculosis, and that is nowadays when a patient who has pulmonary tuberculosis and that patient brings the phlegm up which has a tuberculous pathogen in it, and then swallows the phlegm, that phlegm, when it goes into his stomach and then goes to the large and small intestine, it gets stuck there in the glandular parts in the intestine, and then it starts replicating and infecting there. So that is the etiology, And now let us look at this pathogen before we go on to the pathogenesis. Okay guys, so look at this diagram over here. These are the rod shaped Mycobacterium tuberculosis, which are hominis type. So these rods are the Mycobacterium tuberculosis. One interesting thing about this pathogen is that this has a cell membrane or a membrane that is rich in lipids, and secondly it has lots of small structures that have mannose attached to them. Why is that important? We'll see shortly in the pathogenesis that this mannose is important because macrophages connect with this through the mannose receptors. Check this out. This is also Mycobacterium tuberculosis. This is a close-up view of the colonies that it forms. Normally what happens is that the lipid structures, the lipid in the walls, or the membrane, that lipid just continues to stick with each other, and if you take the close-up out, if you zoom out a little bit, you would actually see that these rod-like structures will make long threads which are called cords. So when you actually see it a little zoomed out, you would see long pink cords in acid-fast stain, so like this. So of course we have zoomed in very much, so this may be just this little part here, and due to that you see the clusters, but if you see, this may be one cord going on. Here this is a acid-fast stain. Mycobacterium tuberculosis is usually stained better with the acid-fast or Ziehl-Neelsen stain or carbon fusin stain, and what happens is that this stain, if you see here, this is actually not one pathogen, this is that cord formation. So this is many pathogens which are rod shaped, and they are now fused with each other or connected with each other through their lipid walls, and so these are the cords of red cords of Mycobacterium tuberculosis present in the tissue. There is one more that you can see here. There is one more that you can see here. Cool. So now let's start the pathogenesis. Alright, so now continuing our discussion, and let's start with the pathogenesis. Look, tuberculosis has to be divided into two primary formats. One is called the primary tuberculosis and the other one is secondary tuberculosis. Both of those are they are possible to either resolve or become progressive. So let's look at that. Let's start with the primary tuberculosis because the pathogenesis is different, the structure, the morphology is different, and the clinical aspects are different. So you have to be able to separate them. Imagine these as two separate diseases. So let's start with the primary tuberculosis. Primary tuberculosis starts with this. So let's say there is a okay, so let's say here is an airway, and this is the pleural surfaces, visceral pleura, the inner green layer, and the parietal pleura, outer green layer. This is the airway, and of course it would continue to divide till it reaches the respiratory zones, and then the rest is the lung parenchyma. Imagine that the pathogen comes in, so this is the pathogen. Pathogen comes into the lung and attaches to the epithelium. Most of the time the pathogen would reach, and I'm making it both in all upper, middle and lower lobes. So let's say the pathogen has reached in the alveoli. We have to figure out what happens the first exposure to the pathogen, what will that do? So this is the primary tuberculosis. This is a situation where the patient or person has never been exposed to this pathogen before, and now this is the first exposure. Now in the first exposure, what happens is the pathogen is, of course, I'm now going to take one piece of this, let's say this one, and let's see what happens. In this alveolus is sitting a macrophage as well. So what is this macrophage? This is alveolar macrophage. So let's go here. This is the alveolar macrophage. This is the nucleus of the macrophage. Macrophage connects with the pathogen in multiple ways. Most important is the mannose binding. So there is mannose present on the pathogen surface, and there is mannan or mannan receptors on the macrophage. That is one mechanism by which macrophage arrests the Mycobacterium tuberculosis. Second mechanism is that the macrophage has, let's make it here, it has the complement binding receptors as well. So let's say this is another pathogen here. On the pathogen surface, C3b complement protein has become attached, C3b, and so macrophage is now connected with the pathogen through the C3b. Then we also know that the pathogen macrophage can connect to the pathogen through the pattern recognition receptors. So these receptors are special proteins that can find various kind of patterns, antigenic patterns on the surface of the pathogen and bind with them. So now various pathogens are stuck with the macrophage. What is the next step? This is normal inflammation, so nothing special here, no rocket science is going on. Next step is that the macrophage is going to phagocytose this pathogen. So let's say this is another macrophage, or this is the same macrophage. Next stage is that the pathogen has become trapped in this phagosome. This is the phagosome. This is also endosome. So endosome or phagosome, same thing. What is the next step? The next step is that the macrophage will activate its internal machinery, microtubular systems, and bring a lysosome and connect it to the phagosome. So let's say over here a bottle of acids is sitting here. What is this bottle? This is the lysosome. What does it have? It has acid hydrolases, it has proteinases, it has DNases, and so many other things that can chop up, that can break up a pathogen. Ideally what happens is, if I bring this structure out here, normally what happens is that the phagocyte or endosome is fused with lysosome, and then pathogen is sitting on one side and is very happy that, hey man, look, I am sitting in this hot tub, I am having fun, my life is happy. This is the Mycobacterium tuberculosis having fun inside the phagosome. However, the acid hydrolases and the proteases, those little monsters, are now spilling over, and they are going to come and they are going to break up the pathogen. However, this step does not happen. This phagosome lysosome fusion is called maturity of the phagosome and formation of phagolysosome. That step does not happen in case of Mycobacterium tuberculosis. This is the root cause of the problem. Now, why does this not happen? It doesn't happen because of a process called manipulation, a step called manipulation by the Mycobacterium tuberculosis. What does Mycobacterium tuberculosis do? Number one, it causes the pH manipulation in the phagosome. Number two, it inhibits various protein activations which allow the phagosome and lysosome to connect with each other. The end result is maturity. This is called maturity, maturation of phagolysosome does not happen. When that maturation will not happen, then what do you think will happen here? Now this pathogen has found a home. It is going to start growing inside the macrophage, and it was also growing, if you come here, outside the macrophage in the alveoli. It is also replicating. So it is replicating in the alveolar spaces, and it is replicating in the macrophages. So after the replication, what will happen? The macrophage will burst open, the pathogen will come out, it would go into the interstitial fluid, it would go into the bloodstream, and bacteremia will occur. Right? So that is the primary way that this pathogen evades the killing. Now, is this a bad thing? Is this TB now? So remember that there are two separate situations. Infection with tuberculosis simply means presence of the tuberculosis inside the lung, and all this mechanism happening. Disease with tuberculosis is when the damage is occurring, and that is the disease. So they are separate. So right now the patient is infected. One possibility now is that the immune system would simply take care of this pathogen, and pathogen will be retained, it will be arrested. So at the most what will happen is there will be some scarring in the area where the pathogen was, and there might be some involvement of the lymph nodes, which we'll talk about it in a second. But the first outcome is that pathogen just got controlled by our immune system and TB did not happen. Second outcome is that the pathogen became dormant. What does that mean? So let's talk about that for a second. So now come back here. Let's say the healing did not happen and the progress of the disease is still continuing. So what is next? What is next is that this macrophage is going to, number one, throw some of the broken pieces of the pathogen out in the tissue. So if I come back here, there will be broken pieces of the pathogen released. Normal function. Second thing, so keep them in mind. Number one, there are antigenic parts of the broken pathogen or mycobacterium released in the interstitium. Number two, the macrophage is now going to start going in the lymphatics, and through the lymphatic channel, it is going to bring this pathogen to where? To the lymph nodes. Why is it going to bring them to the lymph node? It's going to bring it over there to say, look what I got, I have a pathogen, let's fight this pathogen. So let's say this is the lymph node. Who lives in the lymph node? T cells and B cells. T cells, B cells, dendritic cells. These guys are sitting in the lymph node. Macrophage is bringing the pathogen there. The broken pieces of the pathogen are also coming into the lymph node through the lymphatics. The full and pathogen, the complete pathogen, is also washing away into the lymph nodes too. So by 2 to 3 weeks, there is enough exposure and enough presence of the macrophage filled with the pathogen alone, and the antigens of the pathogen that have reached the lymph node. Now what happens in the lymph node? So let's say we make a lymph node over here. So macrophages come in here, antigens have come in here, and some complete pathogens have come in here. When they come in here, what happens is CD4 cells, tuberculosis is a disease of CD4 cell and macrophages. It's a disease of cellular cytotoxicity, remember that. B cells have nothing to do with this. Actually, if our immune system responds to tuberculosis using the B cell, then Mycobacterium leprae would occur, or leprosy will occur, because humoral response cannot take care of intracellular pathogen, and Mycobacterium tuberculosis is intracellular. Okay, so now the pathogen is here. What will happen in this space is, so this is about 3 weeks now. Initial infection could have resolved and nothing happened. That has not resolved, let's say. So the second part is that 3 weeks in, we have the macrophage presenting. So this is the macrophage. On the macrophage MHC2, on the MHC2, macrophage is presenting the antigen or the pathogen to whom? We've done this 1000 times. T cell. Which T cell? CD4 positive or helper T cells. Now what happens? So sensitization would occur, right? So macrophage will bring the antigen there. With that, macrophage is going to release IL-12. Remember IL-12 interferon gamma axis? So this is that. This is the co-stimulation. When IL-12 will come in here, CD4 cells will become activated. When they become activated, what will they do? These will release IL-2 in addition to many other cytokines. IL-2 will cause proliferation of the CD4 cells. So now the CD4 cells are going to start multiplying. The lymph node is going to start becoming swollen with the CD4 cells. Then the CD4 cells would also release what? Interferon gamma. And interferon gamma would activate the macrophage. Why? Because this is an intracellular pathogen and we need the cytotoxic cells to become active to kill the pathogen. Now when the macrophage is active, what will it do? So follow the green side now. Activated macrophage would release chemokines that would attract. So these will be chemoattractants. Right, so what will they do? So let's say if there is this blood vessel, so that is the blood vessel somewhere over here in this area. The blood vessel, the chemoattractants will cause the monocytes to come in. These will cause other T cells to come in. So monocytes, T cells, B cells. So many types of inflammatory cells will start coming in. So as these cells start coming in, what else will happen? So in the chemokines, one important one is tumor necrosis factor. Then there is also IL-1. IL-1 would start causing fevers. Then there are more interleukins that would suppress the appetite in the patient. So the weight loss would start over time. Tumor necrosis factor is caused these things to come in. So now what would happen is the war would start in the area where the pathogens are. Right? So inflammation would start, the reaction would start, hypersensitivity has started. The system, the patient has become, the immune system of the patient has become allergic to this pathogen and the fight has started. That fight will cause what? Look, this pathogen can evade the macrophage. So when everything has become active to kill the pathogen, what will happen to the macrophage now? Let's see. Macrophage, when it is active, other than the chemokines, it will also do this. The gene in the macrophage, so this is one, chemokines. Let's go there. Second, some interleukins. Third, the genes in the macrophage will open up, this is the third thing, to release nitric oxide. That is part of destroying the pathogen. So nitric oxide will be released. Then fourth, there will be release of reactive oxygen species, ROS. all of that once again will try to contain the pathogen and to destroy it. In this process, granulomas will form. So let's see, when this war starts here, when the activation starts here, what will happen in the tissue? So come here, let's see what happens inside the tissue. Now what's happening is, in the tissue and in the primary tuberculosis, this will happen in the middle and lower lobes. Secondary tuberculosis, destruction occurs in the upper lobes. Now what is happening in the middle and lower lobes is that the cells are going to start getting destroyed because of all of this activation and all of the nitric oxide and reactive oxygen species. When the cells are destroyed, they would release a lots of fatty acids. Now Mycobacterium does not like the fatty acid, so wherever the fatty acid is, Mycobacterium runs out of there. It doesn't want to live there. So that central part where the damage is occurring will become cheese-like. This is called caseous necrosis. Necrosis is simply the cell death, and caseous is that cheese-like. Caseous means cheese. So cheese-like appearance would be in the center of the damage. With this over here, the pH will be low as well. So this area is acidic as well because of all of these chemicals that are being released. So the acid plus the oxygen is coming in less because of all the destruction here. So acidic environment with the fatty acids, these environments make the Mycobacterium not grow. Mycobacterium is a slow growing pathogen. It grows, it replicates in about 15 to 20 hours compared to other pathogens that replicate within minutes, or for example E. coli in 20 minutes. So now this has retarded the growth further, so you don't find the Mycobacterium in the cheese-like central part. On the periphery, you would see lot of epithelioid cells. What are these epithelioid? Epithelium-like cells. These are actually macrophages and histiocytes that are converting themselves into these spindle-shaped or fusiform pink-colored cell which have epithelial structure to them, bodies trying to wall off this infection or this damaged area. With that, there will be lots of monocytes and mononuclear infiltrate, which will mean monocyte, T cells, B cells, they are here as well. With that, there are going to be macrophages that are active and sitting here as well, and many macrophages that are trying to take care of this pathogen, and the pathogen is just running around and they cannot kill it. They become frustrated and they fuse, they hold each other's hand and say, we will not let this pathogen go from here. So now when they fuse, they make multinucleated giant cells. Normal structure under the microscope, they appear like this horseshoe shaped cells as well. So this structure is called a necrotizing granuloma or caseous granuloma. What is the structure of this now? Internal cheesy part which has the fatty acids and the cell debris and the acidic environment. Mycobacterium is not found here. Then a rim of epithelioid cells and fibrous repair cells, repair elements, plus mononuclear infiltration, plus giant cells, multinucleated giant cells. Histiocytes are nothing but macrophages and monocytes are called histiocytes. These are the macrophages and monocytes that are present in the tissue. So granuloma formation would occur. That would also mean that calcification, wherever there is damage, there is calcification. Calcification would occur. So when this granuloma would occur, it's a microscopic structure. But when multiple granulomas would keep appearing and they will keep fusing with each other, slowly this microscopic structure will become macroscopic. You can actually see it with the naked eye, and I'll show you the diagram for it. When you can see it with the naked eye, you would see a cheese-like white cheese-like consistency and structure. This is called Ghone focus. So this caseation present in the parenchyma of the lung is called Ghone focus. If the same thing happens in the lymph nodes as well, which it happens, same caseation and same necrosis and same granuloma formations present in the lymph node, then these two things together are called Ghone complex. This calcification, when seen in the X-ray, is called Ranke complex. Ranke's complex is nothing but the presence of the Ghone complex in the lungs. Now this is the second outcome of the first exposure of the primary TB. Normally, even at this stage, we wall off the pathogen, we arrest them in these caseous calcified areas, and the patient becomes okay. Patient had flu-like syndrome, some fever and stuff like that, and he became okay after a few weeks. Now this thing is sitting in his body, and the pathogen here can become reactivated later when the patient is weak. That may be because of age, that may be because patient got some sort of a disease that caused the immunocompromise, that may be patient had some sort of surgery or you gave him some medicines which reduced his immune system strength, for example steroids, that may be bone marrow problems. So somewhere in the future, that may be poverty, patient is not eating well. So somewhere in the future when the patient is weak, this thing can become reactivated, and that will be secondary TB. Now primary TB can stop here and patient is normal. There is a third outcome of the primary TB, and the third outcome is that this structure, so third outcome is that in some patients we cannot contain the mycobacterium easily. For example, there are a group of people who have the NRAMP1 protein in the macrophages that is damaged. And what is the function of that protein? That protein's function is to have, it is present in the phagosome and lysosome. It's an ion channel, NRAMP1. And the function of that protein is to help do the phagocytosis and help activate the phagosomes and lysosomes, or it takes part in their function. So in some people there is a genetic problem and this protein is not well functioning. When that doesn't happen, then we cannot really form this granuloma and stop here. Instead, macrophages are not working well at all, so the TB just continues to become spread. In that case, the patient would have what we call primary progressive tuberculosis. Primary, so if I write here, this is the primary progressive, meaning it would continue, it will not stop, TB. And the primary progressive TB would then cause damage to the lower lobes. It can cause damage to the middle lobe. Normally upper lobes are not involved. It will cause damage to the lymph nodes. So Ghone complex will be present, focus will be present, and then it is possible that the pleural surfaces are involved, and the pleural effusion and pleural infections or empyema or even pneumothorax with the pleural damage can occur. So this is the primary tuberculosis. So guys, why does this maturation failure occur? Not only the phagosome lysosome fusion is blocked, Mycobacterium tuberculosis is very smart. It also blocks apoptosis in the macrophages. So macrophage cannot, in the frustration that it cannot kill the pathogen, macrophage cannot kill itself. Outside cells cannot ask the macrophage to kill itself because it is infected. So now apoptosis is not going to happen. Autophagy by the macrophage, eating itself and killing itself, that is not going to happen. Activation of the macrophage is not happening. Working of the macrophage, the interleukin production, this whole chemokine releases are also stopped. So macrophage essentially becomes a beautiful home for Mycobacterium tuberculosis, in which it just sleeps and have fun and replicates. Look at this slide here. We are looking at this white area. This white area is the Ghon focus. This is a caseous necrosis present in the parenchyma of the lung, and we can actually see lots of cavitation as well. So this is primary plus secondary TB together. Here, this is another example where you can see a large area of the caseous necrosis. Remember, this is not a granuloma. I saw some students who called this a granuloma. Granuloma is a microscopic structure. This is not a microscopic structure, this is a macroscopic structure. So many granulomas that kept coalescing together, that kept merging together to form the structure, and so this is the Ghon focus as well. Look at this. This is the necrotizing granuloma. So if you see here in the center, this all the area here, this all is dead cells, fibrous material, acidic material, fatty acids and stuff like that. As we go outward, pathogen is also moving outward, plus the fight is also happening outward. So here we'll see a lots of mononuclear cells, as you can see from those big lots of dots, plus you'll see lots of fibrous strands here, which is the repair that is happening, plus you see the horseshoe shaped multinucleated giant cells. So look at this. This is one, this is another, this is a giant cell, right? So these giant cells are actually histiocytes or macrophages that have fused together in their frustration to try to take care of this infection and trying to contain it. And then of course you see some more cellularity here, and this is all mononuclear. So this is a necrotizing granuloma. The center is necrotized. Compare this to a non-necrotizing granuloma. Here, this is also a granuloma. You can see the cellularity on the sides. You can see that even inside the granuloma there are cells present. So this is a non-necrotizing granuloma. Maybe this is sarcoidosis, this is something else. Now also remember, necrotizing granuloma is not a diagnosis of tuberculosis. This can happen for many reasons. It can happen because of fungal infections, it can happen because of other infections, it can happen because of immune deficiencies, it can happen because of many other reasons too. Cool. So that concludes the discussion about the primary tuberculosis.